Cool. Well, it's 7:30, so why don't we go ahead and get started? We got a little bit of a group here, and hopefully some more people will trickle in. But good morning, everyone, and welcome back to our weekly CMR conference series hosted at VCU. Every year we start with sort of the basics, especially for some of the new trainees who are joining us. And so this morning we've got Dr. Greg Hundley, who is the director of our VCU Pauley Heart Center and the George Vetrovec Chair of Cardiology and Internal Medicine here at VCU. And so every year he sort of goes through the basics. This is how I learned cardiac MRI, and I think it's a really wonderful way to be introduced to it for those who haven't seen it or need to brush up on the basics. And so without further ado, I'm going to turn it over to him. There's not really going to be any slides. He's going to mostly use the whiteboard. So let me switch over to that and stop the video.
Oh, good. Well, thanks so much, Corey. Can everyone hear me okay? Uh-oh.
Yes.
Shannon,
Yes,
yep.
we can hear y'all.
Okay, good, good. And is the speaker up here or is it that thing over there? Oh, it's
I think it might be built in up there, actually.
Okay. Well, great. Well, good morning, everyone. We're going to take a couple of the class times and just talk about a few fundamental issues related to magnetic resonance imaging. And then as the course goes throughout the year, we'll build on some of these principles and just review fundamentally how we acquire and interpret the images. So the first thing to think about is, how is magnetic resonance imaging different from imaging that we utilize in cardiovascular medicine with other modalities like ultrasound or CT scanning, etc. And so I kind of think about it very simply in this way. Essentially, and I'm going to draw some circles up here. One's given me the teal color. And what I want you to notice with the circles represent protons, hydrogen nuclei. And outside of the core of the magnet in our body, the protons are spinning. And they spin what's meant to represent with these lines going through the circles. They spin in a random fashion. And then once you go up inside the magnet, what does that do? Well, what it does is it takes all of those protons and their associated spins, and believe it or not, lines them up completely parallel to one another. Every single one in your body. It's pretty fantastic. So, is that how we make the image? No. The next thing that we do is we use, non-ionizing electromagnetic radiation. So remember, ionizing electromagnetic radiation, we commonly refer to often as X-rays, right? But we're going to use non-ionizing electromagnetic radiation. And really, that is in the form, believe it or not, of FM radio waves. And for the people that are here in Richmond,
We lost the sound. We can't hear you all.
I'm paused. I was
Oh.
drawing.
Gotcha. Sorry.
So if we're in Richmond, Virginia, it's at somewhere around 88.6 megahertz. Now that's interesting because that is the frequency of transmission of channel 6, the first television station south of the Mason-Dixon line in the United States. Kind of interesting. So what happened when we applied this FM radio frequency? Well, notice what the protons did. They tipped their spins. See up here in the top right, they were organized in one fashion, and then they tip. They all stay parallel, but they tip their spin. Now, they tip their spin in two ways. One way is identified by this line. The other way is, believe it or not, they wind. Okay? So they tip their spins in two ways. One is kind of a transverse tip. The other is they wind up. Well, then after the FM radio wave has gone through, those protons, all of them in your body, go back to their original orientation. Okay, very similar to what was up there in the top right. And when they do, they release energy. And when they release that energy, there are antennae that sit out here, and they pick up that energy. And that's what's used to make the pictures. So you'll hear these sounds when the magnet, when you're in the middle of scanning. And those sounds relate to a couple things, not so much all of the transmissions and things that I'm showing you here, but they relate to some of the magnetic field changes that occur that coincide with some of this FM radio wave transmission. So why did I spend time talking to you about that? Oh, one other thing, where are these antennae located? They pick this up. Well, they're located in two spots. One is if you look at a magnet. Oops, I want to do that. Some of them antenna can be in the bore of the scanner. But the other ones, if you notice, and I'm going to have kind of a person laying in here. There are the arms. You'll see us put this foam thing on top. Well, that's a surface coil, and that also has antenna in it. So why is that scanner in a room that's all closed off? Like when you have scanners that are in the cath lab or CT scanners, we put those in rooms because there's ionizing electromagnetic radiation in the room that we want to prevent from getting out. Why are these pieces of equipment in a room? They are to prevent all of this non-ionizing electromagnetic radiation that are in our environment, from lights, from electrical outlets, from television, radio, etc., from getting in the room and interfering with the picture. And in a couple of weeks, we're going to go through image artifacts, and there are artifacts that occur when this radiation gets in the room and interferes with the process. Now, there's another reason why we want to talk about these this sort of tipping of these spins, and that relates to T1 and T2. You're going to hear these terms. So T2, interestingly, we can look at the time that it takes for these protons to go from this orientation to this orientation right over here, right? And that's in milliseconds. And normally we think about, and this is sort of the rough, you want to be less than or equal to 50 milliseconds in time, all right? And a lot of times, if we think about sort of normal tissues, we're looking at 30 to 40 millisecond time range. So the time that it takes after the FM radio wave has gone through, here it is over here, and after it's gone through, for this to tip back to this orientation in that direction is 50 milliseconds. But remember, there's also this winding process. Well, as we go back over to this, there's the unwinding process, right? And that's going to take a little longer. So that's the T1 time. Now, interestingly, the T2 time, you're going to talk about field strengths of these magnets, right? And we have the magnetic field up here. Mostly, many of you will be working at 1.5 Tesla or 3.0 Tesla, right? The T2 times, this little process right here, stays pretty constant between 1.5 and 3. But the winding and the unwinding, the T1 time, that differs a little bit, right? So at 1.5 Tesla, the number you want to keep in mind is roughly 1,000. So it's going to be less than 1,000 milliseconds. At 3 Tesla, 3.0, it's going to be less than 1,300 milliseconds. And this varies a little bit for the scanner and its location and all that. But it's important to understand how and why, or this operation of this process, and think of it very simply in these terms. You have protons that are spinning outside the magnet, top left, in a random fashion, all right? Then we go inside the magnet and we force all those protons to align their spins. Then we pass through, coming down here, we pass through non-ionizing FM radio wave. That makes all of these protons tip their spins. They all stay parallel. They tip their spins and they wind up. Then after the FM radio wave has gone through, they unwind right here, and they go back to their original orientation. They release energy. We pick that up in antenna. We can time this process, and we look at the T2 time right here by this quick movement from this orientation back to this. And then we have the winding and unwinding process that takes a little bit longer. 1.5 Tesla is usually less than 1,000 milliseconds, and 3 Tesla usually less than 1,300 milliseconds. Okay? So let's go to the images. We're going to look at a case for a second. Any questions on that? All right, so let's scroll up. This is an anonymized case. And what I want you to notice, I want to focus, let's see if you can see, no, you can't see me drawing. Look on your screen at the top right and notice that there are two images in color. Yeah, thanks, Corey, and just leave it right there. So if we look to the left on the monitor or on your screen, you see lots of black and white images. We call that grayscale. But then you have these two color images at the top right. So it's interesting, you know, when I got into this literally 30 years ago, that's kind of scary. And we were doing these black and white images. Back then, we were told that your eye could see 80 shades of gray, from the brightest of white to the darkest of black. If you are in a cave, there's absolutely no light whatsoever. And I looked that up this morning. And of course, you know, as science has evolved and all these things, one study says, oh, you can only see 30 shades. And then some studies say you can see 400 shades. You know, so I pulled up the studies that had 400 shades. Well, I mean, they had, if you can see my screen for those that are online, I'm pointing sort of at this black rectangle box at the bottom. I could not distinguish the 20 shades of black. I mean, it was just insane. So I'm kind of thinking it's more of the, you know, probably the 80 to 100 from brightest white to, there's just not an ability for me to see some of those 400 shades of gray. Well, you'll notice, though, that the gray in the left side of the screen, on your computer screen or here in the room on the monitor, that's fine for observing function. We're going to talk about a little bit later perfusion and things like that. But remember that we had some pretty significant ranges of time intervals for the T1 and the T2. And so how that's expressed, we have to switch to color. Color, our eyes, now some people have color blindness and things like that, but we can see almost 1 million shades of color. All right. And so when we start talking about how we're going to express the T1, remember that was 1,000 milliseconds for 1.5 Tesla. Below that is normal, and 1,300 for the 3 Tesla. Well, how do you do 950 from 978 milliseconds, right? You're going to need more than shades of gray. So that's why you have the pixels and the T1 time or the T2 time expressed in color. All right. We're not going to take the time to do color for all these other images in the top left of the monitor because we don't need that. But for T1 times and T2 times, as part of that proton thing and the FM radio waves and all that, we're going to need more dynamic range. And so that's why they are in color. Okay. Now, on the right side of your screen, or the right side of our monitor, what Dr. Trankel has done is zoomed in on a short axis view of the left ventricle. And so you'll see this purple sort of donut, which is the left ventricular myocardium. And then look in the center of the donut, that's the blood pool. That's the blood pool in the LV cavity. Now, if you look on the left side of this magnified color image, there's a little color scale. It's a vertical bar. And at the bottom, it says 0 milliseconds, which is black. And then you go all the way up to 120 milliseconds, which is bright white. Okay. And remember, we said that for the, and this is a T2 map. we'll talk about what in the world does map mean. This is a T2 map where each pixel represents the T2 value in color. The number in milliseconds has been transferred to a color scale. And they've shown you the color scale in this vertical bar on the left. Okay. So you see this nice, if we were going to think about this color scale, 0 to 120, and down here in the purples is about 40 milliseconds. And you see all around, someone has drawn small regions of interest within the left ventricular myocardium, these little white circles that are embedded in the purple. And if you look, let's follow one of the dotted lines. We're going to take the one to the left, and we come over here, and what they've done is shown you that area of the bottom row of the text here. It says area 0.32 centimeters squared. Well, that's the area of your region of interest. And then the mean, that's the 40 milliseconds. That's the average of all of the pixels within that white region of interest in the interventricular septum. That is the average of those T2 times, 40 milliseconds. And you can look up here and look at the range. It's 32 to 50, and you can see how that works. Now, something you want to remember about T2, why do we spend all this time doing this? It's because that is a really important piece of information. The T2 reflects a lot of the hydrogen bound to oxygen in water, okay? In water. So the T2 time, which is really interesting, reflects how much water is within the region of interest. So look at the center of the cavity. The center of the LV cavity on the image on the right is bright, up near 120 milliseconds. There's a lot of water there. There's a lot of blood, right? Dark purple in the LV myocardium surrounding, not so much water. So the T2 time is helpful if we've got a lot of water and we're measuring that value within the LV myocardium. Can anybody think of what that might indicate? Anybody? What? Inflammation. Okay, so one situation where you could have a lot of extra water in the LV myocardium is if we've got inflammation, right? Myocarditis, right? What's going to happen is the membranes of the myocytes, as well as leakage from the microcirculatory vessels there into the extracellular space, there's going to be more water. So myocarditis, inflammation, any kind of process causing inflammation, that could cause it. What else? Okay, so you could have more edema there if someone has heart failure, right? If the left ventricular end diastolic pressure is elevated, when does the heart muscle perfuse? What part of the cardiac cycle? Diastole, right? Well, if the end diastolic pressure is high, end diastole, then that puts kind of a back pressure against the blood flowing into and exiting that left ventricular myocardium. And so you're going to have extra water in there. So someone that's in decompensated heart failure, there could also be elevated T2. What else? Probably the more important one we've missed.
Ischemia.
Not ischemia, but injury, a myocardial infarction in the acute setting. What happens? The myocytes die, their membranes become permeable, and there's excess water there. So acute myocardial infarction acute congestive heart failure, acute myocarditis, not the chronic phases where all the water's gone, but in the acute phases, that's when the T2 can become elevated. And now you know how you got that measurement, right? Super important to keep that in mind. This is a very powerful tool to identify an acute inflammatory or injury process in the myocardium. All right. Now let's look at this other map. We're going to click on this one. So remember, the T2 is that quick transition. Remember, we go back to our diagram of our protons, and we had that quick angle change. That's only 50 milliseconds. That's a quick period of time. But then we have the winding and the unwinding. That takes longer. The winding and the unwinding takes longer. So now we are in up near 1,000 milliseconds. And at a 3 Tesla, we remembered that it's not 1,000, the number, it's 1,300 milliseconds, right? So here is a T1 map. It's very similar, except the color scale, look at our bar over here. It's 0 up to 2,000 milliseconds, okay? So we need more of that dynamic range. Again, emphasizing why we have a color map as opposed to a grayscale or a black and white, right? We wouldn't be able to distinguish these small changes. And very similarly, you can see this is orange in the LV myocardium in the short axis view. And then you have the white sort of in the blood pool here in the center, okay? If you look, you've got some regions of interest, and I'm over here at basically 8 o'clock, and we come down here. Again, we have the area of that region of interest, 0.27 centimeters squared, so it's a very small area. The mean is 1,243 milliseconds, and we said sort of the target value was 1,300. So what does the T1 tell us? The way I remember T1, for me, it's like the CRP. Something's wrong, but we don't know what. So let's think back a little bit in time, at the time of birth. So remember, we're going to think a little bit about the architecture of the left ventricular myocardium. We're going to think about the architecture. So when all of you in this room and everybody on the Zoom are born, at the time of your birth, you have about 96% of the myocytes that you're going to have for the rest of your life, right when you're born. Okay. What else is in that space? If we take a chunk of this LV myocardium, so we have 96% of the myocytes that we're going to have. That takes up 80%, roughly 80% of the myocardial volume. So if we were to draw a little square around a chunk of myocardium, we're going to have 80% myocytes and then 20% other stuff. Now, those of you that are on the Zoom are not going to be able to see my hand, but I've got my hand standing up here and I'm spreading all of my fingers apart. And so this airspace between my fingers is where those myocytes reside. But they sit on a lattice of what? Fibroblasts. Okay? Fibroblasts hold the myocytes in place, in sheets. Okay? You're going to learn about that in your cardiology fellowship. So we have fibroblasts sitting between the myocytes. What else is in that space? Fat? No. Tiny, maybe microscopic amounts. What else?
Paste. Intercalated fluid.
Nope. The blood vessels. The microcirculation sits in this space, right? How are the myocytes going to get their blood supply, right? So you have some very small, you talk about microcirculatory dysfunction. Okay, you've got little microcirculatory blood vessels in here. You have arterioles, you have capillaries, you have venules. So at the time of birth, we have 96% of the myocytes that we're going to get. They take up 80% roughly of the myocardial volume, and 20% of that volume is other stuff. Right? Now, over that first year of life, then we fill out with another 3.5% of the myocytes we're going to acquire. So at the end of year one, you've got about 99.2% of all the myocytes that you're ever going to have. And then between age 1 and age 4, you get to 100%. Okay. So the myocytes today, in today's technology, they do not regenerate, right? So if we kill the myocytes, right, we're lucky because we've got those fibroblasts and they turn to myofibroblasts and they secrete collagen. And for those of you that cannot see my hand, all of my fingers are coming together and that's what makes the scar. So why am I talking about that? Now we're going to steer back to T1. So what I want you to think about is age 20. Some of you are not far from that. At age 20, if we take a chunk of myocardium, it's about 80% myocytes and 20% of that extracellular space. The fibroblasts, maybe a tiny bit of collagen, and the microcirculation. Once we get to age 70, that shifts. We get older. And the percentages change. And we're down to about 73% myocytes and 27%, 28% of other stuff in the interstitial space. So as we age in time, this T1 value, it's going to be lower. If we were to do teenagers, provided they don't have any other disease process, these T1 values, because of the ratio of myocytes and stuff in the extracellular space, it's going to be at 3 Tesla about, 1,050 milliseconds. And as we get older, so 50 to, 80 years old, that number is going to push up to 73% myocytes and 27% extracellular space. And these T1 values climb to around 1,200. Okay. Now, what happens? What's going on if the T1 value pushes north of 1,300 milliseconds at 3T or 1,000 milliseconds at 1.5T? That ratio of 73% to 27% is going to change. Something else is in the extracellular space. What could that be? Fibrous tissue. Okay, one, it could be more fibrous tissue. It could be replacement or reactive fibrosis. If you look here, there's a little thin start of white right there. See that? That bright color. That could be some fibrous tissue in there. What else could it be? Remember, I said it's non-specific. Water. Okay? If we've got more water in there, the T1 can go up. What else could be in there?
Fatty deposition.
Yeah. Now, fat is a little tricky because we haven't talked about this, but the protons that are bound to carbon in fat have a little bit different spin characteristics than the ones that are bound to oxygen and water. Okay, so if there's fat in there, actually those T1 values can go down, right? But what else can make it go up?
infiltrated
Yes, like what?
amyloid.
Amyloid. If we get another invasive protein in that space. All right. So your T1, when your T1 becomes elevated, something is wrong with that ratio. And it's kind of easy to remember. At age 20, it's about 20% extracellular stuff and 80% is myocytes. As we get older, that ratio changes. If we've got comorbidities, lots of hypertension or diabetes, it varies because, fibrous tissue can get in there, stuff like that. But you want to keep in mind your T1, that unwinding, it has a broad dynamic range. That's why we need a color map. And it's a non-specific measure. Something's wrong. Now, for this particular individual, most all of this is normal, right? Most all of this is normal. So he has normal, this individual has normal T2 and normal T1. That's very reassuring, depending upon the question that you're asking, okay? Everybody get that? Now, one more thing I want to point out. We talked about, see these little, so for those of you that are online, I want you to look at your screen, and Dr. Tranquil is pointing up here in the lungs. And when you have a lot of noise, you kind of get random display up here that you see the air in the lungs, the air outside the body. But the reason I want to point that out to you is look at what comprises the image. It's lots of little cubes. Now in 2 dimensions, when it's displayed on your screen, it's squares, right? So what makes up this picture are lots of little cubes. So let's go back to the white screen now. Anybody have any questions on this? T2, T1, why we do it, how you get the number? Okay. So what we're going to talk about now that image was made of blocks.
Controls.
Yeah, exactly. Those are voxels. So pixels are the front. That's what's displayed on the screen. Right? And so those pixels have dimension. And then there's depth that we don't see. And that's what makes a voxel. So the cube equals voxel. And the display on the screen in 2 dimensions is the pixel. Okay. Now here, the depth of this is going to be, in the world of MRI, your slice thickness. And then here, for the front of this box, the pixel sort of side of it is going to be what we commonly refer to on your screen as your spatial resolution. You got to be careful here, because your spatial resolution in what the scanner sees actually pertains to the whole voxel. But the important point here is we've got to make a picture. And we've got to have, if we're displaying these in just 2 dimensions right now, and remember, our whole thing has some depth to it, right? So here's your Here's your voxel piece, is your depth. So that will figure in. But you've also got the pixel piece, right? And you've got gazillions of these all set up in rows, just like on your television set. So how do we set the spatial resolution of our picture? So one thing that's kind of unique for this technology, every time you start to do a scan, you're running a computer program. Back in the day, when I got started in this is way before you guys, we were sending teams to the moon, right? United States back in 1969, we landed on the moon, and then all through the 70s and 1980s, we were going to the moon. We had cars on the moon running around, rovers. I don't know if they've saved any of all those pictures, but why were we involved with the moon, the astronauts? Remember, well, you guys don't even know. The guys would land, they land in the Pacific Ocean, they get on these ships, and they would say, oh, they're going away for medical testing. Well, where did they come? They actually came to UT Southwestern. That's where I trained. And they all were having MRIs. And why were we were doing MRIs from their toes to the top of their head. Slice, 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 slice. And what were we doing? We were measuring their mass. We were looking at their muscle mass. We were looking at their heart mass. We were looking at all these things. We had to draw regions of interest around every single muscle bundle in their body. It took like a month to do one because it was all by hand. It all had to be verified and checked. But that's how we learned that when you're in space, you lose muscle mass, right? And then we had to come up with exercises and all this. And these were trained, the astronauts back then. I mean, these were some of the sharpest engineers in the United States, but they were also all in their 30s, and they were the top folks in flight classes and stuff like that. They flew jet fighters. A lot of them came from the Air Force. I mean, that's what we were dealing with. So you've got to set the size. When you're running an MRI, it's a little different than when you're doing echo, because you've got to, I mean, why did I get on the NASA thing? I remember at the time, the comments then, and even today, later, when we started doing the space shuttle stuff, the computer systems and all the machinery and the technology involved in those scanners is 4 times what was told to us, what was running the space shuttle. Now, the Apollo aircraft, those were all, it's a lot of manual stuff, right? It's a very sophisticated piece of equipment. The point being that every time you sit down at that thing, you have to set up a computer program that's going to tell you how big you are going to make these images, right? How are you going to set the size of the picture? You do that every single time you run a scan. And how do you do that? How do you set the size of the picture? Does anybody know? One, you create a term that gives the total distance that you're going to cover, and that's called the FOB. Does anybody know what that means? Field of view. Okay, it's the field of view. So you're going to set, if you're thinking about, I'm going to look at an axial slice. So remember, axial, for those of you that are on your computer, axial is like if you went to the fair and you took a saw and you sawed the person in half, they're laying on their back, and you go from their abdomen to their spine. That's axial. That's an axial plane, right? Sagittal is if you start north at the head and go all the way to the toes and cut them right down the middle line through your sternum, your belly button, and all the way down. And then coronal is if you they're laying on their back and you take something that's in the same plane as the tabletop and you slice across. So we talk in MRI or CT about axial, sagittal, and coronal planes, right? So in the axial plane, we're going to understand, remember when you look at these images, we'll go back in a second. The patient's body is here. This is the right side. You say, well, wait a minute. That doesn't make sense. That's the left side of the screen, but the feet are coming out towards you. So this is the right side and this is the left side. And we've got to set the total distance, the field of view in this direction and in this direction. Okay? So that we encompass the target that we're interested to measure. So that's one thing we set. But there's another thing that we have to set. What is that?
Resolution.
Yeah, but what is that?
Matrix.
The matrix. What is the matrix?
By 12 by so the length and breadth, the total.
Well, that's the field of view is the length and the width. What's the matrix? Well, yeah, but what is the matrix? The matrix is the number of lines that you are going to put within the field of view. Okay? And you got these coming down. That's what makes the pixels. You see? That's how we get the squares. So the matrix is going to be the number of lines. Within the field of view. All right. And so a lot of times, we'll have 128 lines by 128 lines. Or sometimes we go to 256 by 256. Or sometimes we go to 512 by 512. Sometimes we go to 90, whatever that is, 92 by 92. You can adjust all of these. But what you're doing is you're taking your field of view and you're dividing it. And we're going to stick either 90 lines in here. So they're going to be far apart. So a small matrix, or let's call it low. A low matrix equals a low spatial resolution. If we take 512 and stick in here, let's go to color. We're going to have a ton of lines in here, right? So a high matrix is a high spatial resolution. Everybody get that? Why is it a high spatial resolution? Because the blocks are tiny, right? You can magnify more. So why wouldn't we, if that's true, why would we have why wouldn't we just have a high matrix within our field of view for every case? You get a great resolution. I mean, it's like This is like high definition TV of the inside of us.
I'm.
Hmm?
I'm.
No, well, we'll talk about temporal resolution next week.
Signal.
Signals. What do you mean by that?
More signal, more brainy is one game.
Here's the trade-off with spatial resolution. Let's go back to, we're going to go back up here to our voxel. What are we imaging? Get back to the first part of the talk. What are we imaging? What?
Proton.
Protons. Okay. This is the trick with MRI. See all these little brown dots in here? Those are meant to be protons in the voxel. All right. Here is a low spatial resolution. And then here is a high spatial resolution. So here's a high spatial resolution. So in the high spatial resolution, how many protons are in here relative to here? Not very many. So guess what? The signal, because we're dependent, remember the whole thing of this? Right? And here we get the energy release. There ain't going to be very many of these guys in this, right? Relative to this. So it's always a balance. If we get over here, this matrix is large. This matrix has very small pixels. This has low signal. This has high signal. It's called signal to noise. So you've got to have enough signal to be able to visualize your target. All right. So what I want you to remember, we talked about having to set the size of our picture. We've got a very complicated piece of machinery. We're going to talk about next week how we make those cine movies. But each time you walk up to it, you are setting the size of the picture. It's not like an echo machine. I mean, you change the depth a little bit, but you walk up and boom, you're getting, that's all set for you. It's not like in the cath lab. All right. Not like in the CT scanner. All right. What you're doing is every time you walk up, you are setting what the size of the picture is going to be. And we're going to talk about what's interesting. You have to set the size. If you set the size of this picture to here, the problem that you get is this part of the person wraps into the image. We're going to talk about that later. You're going to see examples of that. Okay. But you have to set the size of the picture. But you've got to be thinking that this picture is made up of these voxels. And you're imaging those protons and how they behave in that magnetic field with that FM radio wave thing. Right? If you've got lots of protons in your voxel, you're going to be able to see things. If you set your spatial resolution too high, making your matrix very high number like this, you don't have as many protons, there's not going to be enough signal, and the thing starts to just gray out. Right? So it's a balance. You're adjusting your field of view and your matrix size so that you have an appropriate signal to understand the target that you're trying to image. Okay. So in summary, we've talked about the basic fundamentals of the imaging process, right? We're not looking at reflection of ultrasound. We're not looking at diffraction of X-rays in the cath lab in the CT scanner. What we're doing is we're imaging protons. Those protons are bound to carbon, primarily in fat, and oxygen in water. We're going to focus mostly on the water ones, but we'll talk about next week some differences in how we can separate the two out. Carbon ones, carbon-bound hydrogen from oxygen-bound hydrogen, okay? But fundamentally, what we're going to do is up inside the bore of the scanner, what happens, that magnetic field makes all the protons in our body line up in a specific orientation, every single one. The more protons you've got in there, the better your pictures. If a big person can fit in the hole, there's better pictures. There's more protons, okay? But it's fitting in there and being comfortable and all that, you know, you push up against the bore, it's all kinds of yuckiness. It gets real tight and all that kind of thing. So that's not a big limitation for us, right? Then we take FM radio waves. In Richmond, it's right around 8 point whatever it is megahertz. We keep that scanner in a room secluded because we don't want the non-ionizing electromagnetic radiation in our environment. It comes out of these lights, that comes out of the wall sockets, that comes out of the FM radio waves from interfering with the picture-taking process. We pass the FM radio waves through, the hydrogen tips their spins, and then after the FM radio waves gone through, they go back to their original orientation. When they do, they release energy. We can time that. We can time that. We have the T2, it's really quick, 50 milliseconds. 3T or 1.5. Longer the unwinding, that's T1. Why would we use a 3T scanner? It winds the protons tighter, and then when they go back to their original orientation, they release more energy. That's the advantage of 3T versus 1.5. You get more signal because there's more unwinding. Okay, you want to think about it that way. We talked about what those values were. 50 milliseconds roughly for 1.5 and 3T for T2, 1000 for 1.5 for T1, 1300 for 3T. Okay, what does T2 tell us? Water. When's water going to be in the myocardium? Injury, inflammation, edema related to decompensated heart failure. T1, there's something wrong with the ratio. It's non-specific. We don't know. 80%, 20%, 80% myocytes, 20% other stuff when you're 20 years old. As we get older, that ratio changes. The T1 changes as you get older over time, okay? It's non-specific. Something's wrong with the ratio. The myocyte to extracellular space ratio is perturbed. It could be because there's water there. It could be because there's collagen there. It could be because there's more reactive fibrosis. There could be interstitial fibrosis. You want to know that there's fibroblasts sitting in there, and when they're perturbed, thank goodness we've got them in there, because they convert to myofibroblasts. They'll secrete collagen. That's what makes a scar in the setting of a myocardial infarction. But that process can be activated independently for other reasons. People with diabetes, people with high blood pressure, they get activated and you have interstitial fibrosis. We could talk more about that when we're down here, you're reviewing cases as you go through, okay? That's T1. Could be an infiltrative process gets in there. Amyloid protein gets in that interstitial space. That's going to drive those T1 values. If you're at 1.5T to 1200, if you're at 3T to 1450, okay? It's a good clue. Then we talked about it's a very sophisticated piece of equipment, and we have to set the picture size. We do that by manipulating two things. One, the field of view, this total distance, right? And then adjusting the matrix, how many lines we're gonna put in that space. Like this. If we crank up the spatial resolution, we make the matrix really high, we make the field of view small. I mean, this is a big field of view. Suppose we take the field of view and we make it like this. And we stick 512 lines in there. My gosh, oh my gosh. You know, oh, we could see, you know, this is something you should know about. You remember Mr. Obama activated a program. They wanted to be able to see in the brain kind of the dendrites. So what did they do? They went from 3 Tesla past 7 Tesla to 10 Tesla. Right? Remember? Winding, unwinding. We're winding them tighter. There's more energy release. That allows you to really crank the matrix and get high spatial resolution. But at the field strengths that we're using right now, 3T and 1.5T, you know, we're not necessarily able to do that. If you ever have a scan on a 7T or a 10, I've been in one, you come out and you're like swimming. Okay, some of the larger academic, yeah, it really, your ear canals and all that kind of stuff, you're really kind of swimming when you get that done. But you can have some really sophisticated images done. But anyway, matrix size and field of view, okay? Why do one quick thing that you need to keep in mind, as you go up in these field strengths, this whole process, and we're going to talk about next week, gets very sensitive to motion. Okay, well, guess what? You're doing cardiovascular work. Heart's moving, people are breathing, blood is flowing. So we're going to talk about that next week, and temporal resolution. The higher you go here, the more artifacts you get from motion. So actually, this field strength for many cardiovascular applications, particularly if you're doing congenital heart disease and you're going to do a lot of blood flow measurements, this field strength is much better. Okay, we're going to talk about that next week. Okay, well, we're a little bit over. Sorry for doing that. I've got to run and go, but that's sort of the first lecture one. Helps you at least a little bit better understand as you start to use this with the Lord.
Thanks so much. Yeah, Shannon, if you don't mind putting up the see me slide, let me stop sharing. And thank you, Dr. Hundley, and look forward to next week's session.